In this presentation, the reconstruction of a three-part fracture of the proximal humerus will be demonstrated using the multiloc proximal humeral nail. This presentation will show the indications, an introduction to the nailing system, pre-operative planning, the patient position and surgical approach, fracture reduction, locating the entry point, nail insertion and locking, and implant removal. The multiloc proximal humeral nail is indicated for fractures of the proximal humerus, including two-part surgical neck fractures, three-part fractures, and four-part fractures. In this case, a 78-year-old woman suffered a two-part surgical neck fracture resulting from a simple fall. The fracture was treated with an 8mm multiloc PHN, 3 multiloc screws, and standard distal locking. In this case, a 53-year-old woman suffered a three-part fracture resulting from a simple fall. Following 6 weeks of conservative treatment with severe pain and impossible active rehabilitation, the fracture was treated with a 9.5mm multiloc PHN, 3 multiloc screws, and a 3.5mm locking screw used as a screw-in-screw. For the ascending screw and the distal locking, an angular stable locking system, ASLS, was used. In the third case, an 8-year-old woman suffered a four-part fracture resulting from a simple fall. The fracture was treated with an 8mm multiloc PHN, 3 multiloc screws, a 3.5mm locking screw used as a screw-in-screw, suture fixation of the minor tuberosity fragment, and standard distal locking. The multiloc proximal humeral nail is a flexible system featuring multiple locking options for simple and complex fractures. Right and left cannulated nails in diameters of 8.0 and 9.5mm are available. The straight nail design allows a central insertion point. An improved anchorage in strong subchondral bone, the potential to avoid insertion through the fracture site in typical three-part fractures, and preservation of the hypovascular supraspinatus footprint. The proximal locking holes, levels A to D, have a polyethylene inlay for angular stability and to reduce instances of screw backout. The ascending screw, level E, provides support for the calcar, especially in medially comminuted fractures. The multiplanar distal locking screws, levels F and G, reduce implant toggling in the humeral canal. The 3 lateral multiloc screws at levels A, B, and D must be used in any fracture situation to ensure the basic stability of the construct. An additional anterior multiloc screw at level C may be used in fractures with a minor tuberosity fragment, if the fragment is large enough to accommodate the screw head. The multiloc screw features a blunt screw tip to minimize the risk of secondary screw perforation, 4 suture holes for reliable attachment of the rotator cuff muscles, and a countersunk screw head to reduce implant prominence. Secondary screw-in-screw 3.5mm locking screws can be used for improved stability, especially in cases of poor bone quality, for example, osteoporotic bone. These screws provide support for the posteromedial region, where the strongest bone mineral density is found. The preoperative planner template for the multiloc proximal humeral nail is used to estimate the nail diameter and screw positions. The patient is positioned in a beach chair position on a radiolucent table. The shoulder is supported with pads and the fractured arm is placed on an adjustable side table or armrest. Make sure that the arm can be sufficiently reclined to expose the humeral head anterior to the acromion. The image intensifier is placed so that the entire humerus can be visualized in two planes, for example at the head of the patient or contralateral to the injured arm. Alternatively, the patient can be placed in a modified supine position, tilted 30 to 40 degrees towards contralateral on a completely radiolucent table to allow intraoperative movement of the arm. An anterolateral approach is performed. The incision is begun at the anterolateral tip of the acromion and carried distally over the deltoid muscle. The deltoid muscle is split at the tendinous intersection between its anterior and middle third, along the fibers, and retracted. The fracture model is a three-part varus displaced fracture with posterior-medial impaction and distraction on the lateral side, with some periosteal connections between the greater tuberosity and the diaphysis. The large fragment of the greater tuberosity is displaced posteriorly and a little medial. The fracture is reduced using indirect reduction maneuvers, traction sutures, an elevator, or with shank screws or K-wires used as joysticks. 3 sutures are inserted through the rotator cuff. The first suture is at the insertion of the supraspinatus tendon to control and reduce the varus displacement. Using traction, the head can be brought into valgus displacement and achieve some reduction. The second suture is placed at the insertion of the subscapularis muscle to help reduce the minor tuberosity fragment. The third suture is placed at the insertion of the infraspinatus tendon on the greater tuberosity to bring this fragment into reduction against the head fragment. Tension is applied to the sutures and a periosteal elevator is used to reduce the greater tuberosity fragment. A K-wire is inserted to temporarily hold the reduction in place. A second K-wire is inserted posterior to the bicipital tendon. It is important that the K-wires do not hinder nail insertion. These K-wires are used as joysticks to manipulate the head fragment into a more valgus reduced position and correct the retroversion and rotation. An additional K-wire is inserted to fix the head fragment against the diaphysial fragment. The ideal entry point is situated at the apex of the humeral head, in line with the medullary canal, in both AP and lateral views. This point is located posterolateral to the biceps tendon and medial to the sulcus, between the greater tuberosity and the humeral head. The instruments needed to open the humerus are the 2.5 mm guide rod with stop and trocar tip, the small universal chuck with T-handle, the protection sleeve, and the 10 mm hollow drill bit. When the patient is in the beach chair position, the acromion inhibits access to the ideal entry point. The arm should be reclined 20 to 30 degrees to move the apex of the humeral head in front of the acromion. The guide rod is partially inserted at the appropriate entry point. The position of the guide rod is checked in both the AP and lateral views. A longitudinal incision of 1 to 2 cm is made through the supraspinatus tendon along its fibers at the position of the guide rod. Holding sutures are used to obtain access to the operative field. The guide rod is advanced until its stop reaches the bone surface. Care is taken not to damage the hypovascular zone of the rotator cuff near its insertion on the humerus. The protection sleeve is passed over the guide rod down to the bone. The 10 mm hollow drill bit is passed over the guide rod and through the protection sleeve to the bone. Drilling is performed to the depth of the medullary canal. The hollow drill bit, the guide rod, and the protection sleeve are removed. The removed bone cylinder shows that in the fracture situation there is still a ring of intact cartilage and subchondral bone surrounding the insertion hole. Therefore, the proximal end of the nail will act as a fifth anchor point. The instruments needed to insert the nail are the insertion handle, the connecting screw, and the combination wrench. The insertion handle is oriented laterally, and the geometry of the insertion handle is matched to the nail. The connecting screw is passed through the insertion handle and into the nail, and tightened manually. The assembly is secured with the combination wrench. The nail is inserted into the medullary canal and advanced using twisting motions with the insertion handle oriented laterally. The passage of the nail across the fracture is monitored and controlled in two planes to avoid misalignment. The nail position is checked in the AP and lateral views. To avoid impingement, the proximal end of the nail must be inserted below the surface of the humeral head. A hammer should not be used, as it may increase the risk of iatrogenic fractures. When advancing the nail, pressure against the elbow can prevent distraction and potential healing problems. The position of the nail is checked using the lateral aiming arm, the anterior aiming arm, the 2.5mm K-wire with trocar tip, the 13.0 10.0 protection sleeve, and the 10.0 3.8 drill sleeve. Ensure the lateral aiming arm is oriented correctly by verifying that it shows right for the right humerus or left for the left humerus. The connecting screw is inserted into the aiming arm and tightened. The proximal nail position is checked clinically and under image intensification. A 2.5mm K-wire can be placed through the hole in the aiming arm marked 0 to better identify the proximal nail end. To maximize stability while minimizing the risk of impingement, the proximal nail end should be at least 2 to 3 mm below the cartilage. If the ascending screw will be used, the anterior aiming arm is connected to the insertion handle. A 2.5mm K-wire is placed through the hole in the anterior aiming arm marked Ascend. The position of the image intensifier, or the patient's arm, is adjusted so that the circle of the anterior aiming arm aligns with the screw hole in the nail for the anterior screw. The K-wire will indicate the position of the ascending screw. The insertion depth of the nail is adjusted so that the ascending screw will be positioned within the calcar region. The protection sleeve and drill sleeve are inserted through the most proximal hole of the lateral aiming arm. The holes for the multiloc screws are marked with an orange circle. A protection sleeve and drill sleeve are inserted through the anterior hole of the lateral aiming arm down to the bone. A screw inserted through this hole should be placed as anteriorly as possible without injuring the long biceps tendon. No screws should be placed in the bicipital groove. If necessary, the nail is rotated slightly. A 2.5mm K-wire is used for temporary fixation. To insert the multiloc screws, the following instruments are needed: the calibrated 3.8mm drill bit, the conical 6.5mm drill bit with stop, the length probe, and the screwdriver for 4.5mm multiloc screws with self-holding mechanism. The protection sleeve and drill sleeve are moved from the proximal hole to the posterior hole in the aiming arm. The calibrated drill bit is inserted and carefully advanced until the level of the subchondral bone is reached. Care is taken not to penetrate the articular surface. The position of the drill bit is confirmed with the image intensifier. The required length of the screw is read directly from the calibrated drill bit at the back of the drill sleeve. The drill sleeve must be pressed firmly to the cortex to ensure accurate measurement. The drill bit and the drill sleeve are removed. As an alternative, the screw length can be determined with the length probe. The length probe is inserted through the protection sleeve and advanced under image intensification until the resistance of the subchondral space is felt. To ensure accurate measurement, the outer part of the length probe is pressed firmly to the cortex. When positioned correctly, the orange marking on the length probe will align with the outer opening of the protection sleeve. The screw length is read directly from the length probe at the back of the outer sleeve. In hard bone, the lateral cortex is over-drilled with the 6.5 mm conical drill bit to allow the multiloc screw to be countersunk. To connect the multiloc screw to the screwdriver, the knob is pulled back and the screw is attached. The knob is then pushed forward to lock the screw into place. The screw is slid through the protection sleeve and inserted until it is properly countersunk. Do not over-insert. The orange marking on the shaft of the screwdriver can be used as an indicator of the correct screw insertion depth. The final position of the screwdriver handle must be perpendicular to the nail with the arrow pointing posteriorly. The position of the screw is verified under image intensification. To release the screwdriver, the knob on the handle is pulled back. The protection sleeve is removed. This position will allow suture fixation while avoiding the risk of impingement. The next multiloc screw is inserted through the proximal hole in the aiming arm using the same technique. The K-wire is removed and replaced by a third multiloc screw. The 3 lateral multiloc screws must be used in any fracture situation, as they ensure the basic stability of the construct. An anterior multiloc screw may be used in fractures with a minor tuberosity fragment, if the fragment is large enough to accommodate the screw head. If the anterior screw is used, the anterior aiming arm is mounted on the insertion handle. The multiloc screw is inserted in the same manner as the others. It should be noted that a 3.5 mm locking screw should not be inserted through this screw. The final position of all multiloc screws is carefully inspected under image intensification in 2 planes to ensure that they do not penetrate the articular surface. Both aiming arms are now removed along with the K-wires. To insert the 3.5 mm locking screws, the following instruments are needed: the 9.8 5.8 centering sleeve, the 5.8 2.8 drill sleeve, the 2.8 mm LCP drill bit with stop, the length probe, the 1.5 Newton-meter torque limiter, the handle with quick coupling, and the T15 star drive screwdriver shaft. The centering sleeve is attached to the multiloc screw and gently tilted anteriorly. The drill sleeve is locked in the centering sleeve by clicking it into place. The 2 handles of the drill sleeve must be perpendicular to the nail. If necessary, the drill sleeve is rotated. The drill bit is inserted and carefully advanced until the level of the subchondral bone is reached. Care is taken not to penetrate the articular surface. The position of the drill bit is checked under image intensification. The required screw length is read directly from the calibrated drill bit at the back of the drill sleeve. As an alternative, the length probe can be used. It is inserted through the drill sleeve and advanced under image intensification until the resistance of the subchondral space is felt. The screw length is read from the scale on the length probe. The drill sleeve is removed without changing the position of the centering sleeve. The appropriate length 3.5 mm locking screw is inserted through the centering sleeve and tightened until a click is heard and felt. Once the locking screw is fully seated, the centering sleeve is removed. The instruments needed for the insertion of the ascending and distal locking screws are the 12.0 8.0 protection sleeve, the 8.0 3.2 drill sleeve, the 3.2 mm drill bit, the depth gauge, and the T25 star drive screwdriver. To provide additional support for the calcar, an ascending screw can be inserted. However, before this screw is inserted, the axillary nerve must be protected, but not necessarily identified, to prevent injury to the nerve and its branches. The lateral aiming arm is reattached. The protection sleeve and the drill sleeve are inserted through the most distal hole in the aiming arm. The calibrated drill bit is inserted and carefully advanced until the level of the subchondral bone is reached, making sure not to penetrate the articular surface. The drill bit position is confirmed under image intensification. The required length of the screw is read directly from the calibrated drill bit at the back of the drill sleeve. The drill bit and the drill sleeve are removed. As an alternative, the depth gauge can be used to measure the appropriate screw length. The screw length is read directly from the depth gauge. The appropriate length 4.0 mm locking screw is inserted using the T25 star drive screwdriver through the protection sleeve. The protection sleeve is removed. The protection sleeve and the drill sleeve are inserted through one of the distal holes in the aiming arm and advanced down to the bone. The calibrated drill bit is inserted and both cortices are drilled until the tip of the drill bit just perforates the medial cortex. To ensure accurate measurement, the drill sleeve is pressed firmly to the cortex. The drill bit position is confirmed under image intensification. The required length of the screw is read directly from the calibrated drill bit at the back of the drill sleeve. As an alternative, the depth gauge can be used to measure the appropriate screw length. The screw length is read directly from the depth gauge. The appropriate length 4.0 mm locking screw is inserted using the T25 star drive screwdriver through the protection sleeve. The second 4.0 mm locking screw is inserted in the same manner as the first. In cases where increased stability is needed, such as fractures closer to the metaphyseal area or in poor quality bone, the angular stable locking system, ASLS, may be used. The end caps come with extensions from 0 mm to 15 mm. They are inserted with the T25 star drive screwdriver. To select the correct end cap, a 2.5 mm K-wire is inserted through the corresponding end cap hole in the proximal portion of the aiming arm. The extension length is estimated using an AP image of the proximal nail end. The grooves on the insertion handle can be used to help identify the insertion depth under image intensification. To avoid impingement, the end cap must be inserted securely below the surface of the humeral head. The K-wire and then the lateral aiming arm are now removed. The insertion handle is removed by loosening the connecting screw. To minimize the chance of cross-threading, the end cap is turned anti-clockwise until the thread of the end cap aligns with the thread of the nail, then clockwise to securely tighten the end cap. 2 or 3 sutures are used to close the rotator cuff over the end cap. Here is the final fixation. The stability of the fixation can be improved with the insertion of sutures. 1 or more heavy, non-absorbable sutures are placed in the region of the tendinous insertion of the supraspinatus, infraspinatus, and subscapularis muscle. The sutures are attached to the multiloc screws by threading them through the suture holes in the screw head. The anterior and posterior sutures can also be knotted together. Here is the posterior medial defect that was caused by the varus posterior impaction. After anatomical reduction, a defect still exists on the medial side. The advantage of the multiloc in treating these defects is that it is biomechanically closer to the defect area, and therefore less moment forces are acting upon the implant, and a higher stability is assured. To remove the implant, the following instruments are needed: the T25 star drive screwdriver, the extraction screw, the small star drive screwdriver shaft, the handle with quick coupling, the extraction shaft for multi-lock screws, and the combined hammer. The T25 star drive screwdriver is used to remove the end cap. The extraction screw is threaded into the nail. If any screws in screws were used, the screwdriver shaft and handle are assembled and used to remove the 3.5mm locking screws first. The extraction shaft and handle are assembled and used to remove all the multilock screws. All 4.0mm locking screws are removed with the T25 star drive screwdriver. The nail is withdrawn. If any resistance is encountered, gentle hammer blows can be used to extract the nail. The rotator cuff must be sutured after nail removal. This presentation has shown the indications, an introduction to the nailing system, pre-operative planning, the patient position and surgical approach, fracture reduction, locating the entry point, nail insertion and locking, and implant removal.